Good morning, everybody. How's everyone doing so far? Good, good. So, I mean, we've already gotten to see a lot of good and exciting information, and I think there's a whole lot to still come. And, you know, one of the things I really wanted to talk a little bit about was what's pretty exciting about urology and prostate cancer is that there's a lot of emerging technologies. And I think, you know, we live in a world right now where we're somewhat used to all of this technology. I mean, I think everyone in this room probably has a smartphone. You know, we're used to that whole evolution of going from, you know, corded phones to large flip phones and then now to smartphones where you can literally do everything right here. And that technology evolves as part of our normal day. But that also happens in medicine, and that also happens in urology, that also happens in surgery. And I think, you know, people have been talking about clinical trials. I mean, that's how these things, you know, emerge of what treatments are actually useful or not. So I wanted to spend a little bit of time here just talking about some of these, you know, emerging technologies, especially in the world of prostate cancer. A lot of people might remember the days of Nintendo. That's kind of what I grew up with, and sitting on the floor just like these kids. I mean, you know, you didn't care about a couch, you didn't care how far you were from the TV, you were just so engrossed in playing these video games. And you know, through a remote control, you're able to control what's happening on the screen. And, you know, you're not thinking of what limitations exist here, right? That it's a 2D image. It doesn't matter. You're just running side to side on a screen. But, you know, then they come out with a power glove, and now you're really part of that. Like, I move my hand, and it moves on the screen. So, I mean, you know, video games and technology has kind of been part of our lives, and it's kind of really transitioned to where that was a lot of my interest when, you know, growing up. And so as I came into urology and I learned that we can play with lasers for kidney stones or robots for surgery, I mean, it was kind of a natural transition to actually consider thinking about the use of technology. Robots are quite popular in you know, pop culture here. I think almost everyone in the room can identify a few of these robots that have become standard. And you know, everyone has these envisions of what a robot is, that this, you know, device that kind of takes care of things, does everything for you, doesn't really need much human, you know, interaction to function. And I bring this up because as we talk about surgery, you know, there's the Vinci surgical robot that has become very popularized, and there are other brands that are out there, but one common question that comes up is, do you even do the surgery or the robot does the whole thing? And I think that's that conception based off of, you know, what we know of robots. I put this up here because, you know, Wired magazine, you know, kind of looking at different tech pieces, when they were kind of naming the 50 best robots, the Da Vinci surgical system was number 8 on their list. So it's really found a great place in surgery. And, you know, one of the things about it is that, you know, we still have a lot of patients who are kind of like, well, will this be done robotically? And I want to kind of talk about what that all means moving forward. So, you know, surgical robots in general have a lot of uses, and it's not just strictly for urology, it's not just for prostate cancer, but it's used all across the board in various subspecialties. And, you know, it's quickly becoming the standard. And one of the main things that if you think of playing a video game and you've got, you know, a 2D image on the screen moving side to side, or you're wearing a power glove that you really are limited to certain movements, up, down, left, right, but maybe not so much like a wrist turn or something like that. That's where the evolution of surgery has happened, from an open surgery to what's called laparoscopic, using minimally invasive instruments, but it is still somewhat rigid to where we've moved into robotics that allow you that full dexterity of twisting your wrist and really completing a full surgery. So when we look at the evolution of, and I use Da Vinci because that's, you know, the robot that's been around for the longest here, and it's the most popularized, you know, it's been around for well over 20 years. And I don't think that that information is really conveyed a lot to patients, because a lot of patients come in like, this is a new technology that's been here. Do you do robotics or not? And, you know, it's been here for 20 years. And when you look at kind of the graphic here of the evolution of the robot, it's constantly, you know, focused around main ideas of 3D visualization, So compared to that Nintendo screen of a 2D image, you now can see things in 3D, but also that actual wrist motion. Now I have the full capabilities of what my hand can do inside the body, and I think those are really key parts of it. Another part that's very important to recognize is magnification. I mean, everyone can kind of hold their phone out and read the clock. I mean, you might even be able to read the clock from there, but can you see the pixels? Can you see the actual fine points that make up that image, right? We can't see a lot of that with our naked eye, but, many people in here wear glasses. We have magnifying loops for surgery. We have these things. The robot can then magnify that, 10 plus times what we can see. So when we talk about nerve sparing, we talk about incontinence, we talk about erectile dysfunction, these things matter. And that's where that precision really comes in, that we think we're good, but we know robots can help us be better. And so when we look at the evolution of this, that's what we see. And to the point all the way on the far right, now they're saying that, it's a single site surgery, right? Instead of having a large incision for an open surgery or multiple small ports for a robotic surgery, how about just having one small incision, sticking this instrument and having these all come out of that, where you have a camera at the top and then you have those 3 arms at the bottom doing the surgery. So that's where this technology is really trying to improve patient outcomes as well as kind of recovery after surgery. So there's a lot of evolution that's gone into this. And I know that word just gets thrown out there like, oh, robotic surgery, but understand there's 20 years of history and technology that go into that next evolution. I brought up Da Vinci because, as I said before, they are the most popularized. They are the one that's kind of become the preeminent platform. And a lot of that is because these were installed at a lot of the training centers. So residents coming out during training were trained on this. So as you come into the real world, it becomes a marketing piece. Like, I want to offer a robotic prostatectomy, but you don't have a robot at your hospital. You need to get one. This is not just in urology. This is in all those areas of surgery that I was showing you. So, all of the graduating doctors are trained on a robotic platform that it's quickly become the standard. Hospitals are behind the times if they don't have a robot, and it becomes part of the recruitment to get new doctors that, hey, we've got a robot here, so that they keep up with those same surgical skills. So you can see, and this is very old data. This is over 10 plus 15 years ago of what the map is. I'm sure you can imagine what the map shows now, but you see the widespread population of the robots. So I've talked a lot about kind of the benefits for it, and just want to kind of show, I don't know how many people are very familiar with a robotic prostatectomy, have ever used the robot, been in a room. I'm sure people have watched YouTube videos. But you have a surgeon who is looking in a console, and that allows you to see the images in 3D at a 10 plus X magnification. So you're looking in a box, and then all the way, and that box is right there, what's in the middle. So the middle is the 2, eye sockets, and you're just putting your head in there, and you're looking in. Your hands are controlling those instruments over on the far right, and so you put your fingers actually into these slots, and it's kind of like a pincer grasp, and then it's literally like you're holding something, but it controls your entire movement. So it's very fine-tuning to what you can do with this. So everyone thinks of things, when you see people dancing like a robot at the, on videos, or you always imagine kind of very rigid type movements. This is very fine, that just what you can do with your hand of actually a wrist articulation. So that's kind of how the basis of the robot. I've got an animation video here that will show that just kind of demonstrates a lot of what we're talking about, of that fine movement and how it allows you to separate the prostate from the nerves and actually remove the prostate.
Surgical system.
So this is where I was just talking about how you see the surgeon with the head in the console.
And a patient-side robotic system with a high-resolution camera and micro-instruments used in surgery. The computer-enhanced system scales the
You can see the surgeon's fingers right there in the graspers.
Micro-movements of the surgical instruments on the patient-side system. Unlike standard laparoscopic instruments, the specialized Da Vinci instruments can articulate and rotate 360 degrees with unparalleled precision and flexibility. The camera of the system provides the surgeon with a remarkably clear, three-dimensional view inside the body. Looking inside the pelvis, the anatomy around the prostate consists of muscles and delicate nerves that affect both urination and erections. During the removal of the cancerous prostate, your surgeon works to spare these very delicate structures, utilizing the articulating Da Vinci instruments and a highly magnified 3D view of the anatomy provided by the system. This added control and precision may assist the surgeon in preserving the anatomy necessary for urinary continence, as well as the nerve bundles responsible for erections. Once the prostate is cleanly detached, the prostate is then removed through a small incision. The bladder is reattached to the urine channel over a catheter. This catheter is left in place for a short period of time to ensure proper healing. The surgery is completed with the removal of the instruments and the closure of the small incisions in the abdomen.
So you can see right there, I mean, it really allows for a lot of that articulation, a lot of that fine movement. I mean, you know, in that animation, it makes it look very simple, but there's a lot more that goes to really separating those nerves off of the prostate, and you can envision just kind of how much, you know, fine movement you need in that. So as we look at, you know, I've discussed the Da Vinci robot, but there are other existing robots that, you know, are currently there and are currently emerging, and these are just a few of them that are trying to, as we talked about this evolution of technology, trying to see, well, what are some limitations that exist, you know? Instead of having the surgeon's head in a console and you're not really aware of much peripheral vision, can we have something that's a little standalone that you're still aware of what's happening in the operating room? Can we have something, instead of having one device that has 4 robotic arms, can we have 4 separate arms? And would that allow a little bit more mobility? What's going to help improve these outcomes with surgery? So that's what we see here with a lot of these that are, you know, based more in the US, in Europe, in Korea, but there's a lot of other surgical platforms that are happening. So I wanted to kind of shift. I didn't want to spend this whole talk about a robotic prostatectomy because, like I said, that's been there for 20 years, and there's a lot of new and exciting things that have really been happening with prostate cancer as we go through this. And so one of the things, you know, I wanted to bring up that how many people in here are aware of what a fusion prostate biopsy is? All right, so I would say we're looking at about 10% of the room. And what's crazy is this really is something that is quickly becoming a standard for how we diagnose prostate cancer. And the analogy I always tell everybody, right? If I give everyone in here an orange, and there's a bad seed in that orange, and I give you 12 toothpicks, right? And say, hit the bad seed. But then this half of the room, I'm going to give you a map that shows you where the bad seed is. And we're going to compare how many people on this side with the map can hit the bad seed compared to this side of the room, how many people can hit the bad seed without the map. What do you think the results would be? That's kind of the easy way of how I describe a standard prostate biopsy versus a fusion prostate biopsy. A fusion prostate biopsy has really utilized an MRI. And I think MRIs are quickly becoming a standard part of an evaluation for prostate cancer. It used to be only after you were diagnosed with prostate cancer, and now it's really being utilized beforehand. And that's giving us a good sense of where do we need to target and focus in your biopsy in order to maximize that diagnosis, to really get an accurate diagnosis. And so that's what you see here on these images, that it's actually cool technology where you're taking an MRI, which is up there, which is on the bottom, and you are in real time tracking it to an ultrasound at the time of biopsy, which is the image at the top left, to create a 3D image of the prostate which is over on the far right, where you have that green abnormal area that was seen on your MRI, tracked to your prostate during ultrasound, so we can now specifically target that biopsy. And so how that works is, a patient gets an MRI, we get these MRI images, and then on the top right are the MRI images, and the bottom left is the ultrasound images. And the reason this has come up is because ultrasound is not as good at detecting some of these smaller abnormal masses. We're detecting prostate cancer a lot earlier. We can't always see an abnormality on ultrasound, so the MRI provides that guidance, and we fuse those two images on top of each other in order to then conduct a biopsy in real time, which is seen there on the bottom right. So I've got a quick animation. I know I've got a lot of animations here, but I think it really gets the image across of kind of how some of these technologies work better than me just trying to describe it. So this is kind of just how a fusion biopsy works, and then I'll explain it. I don't think this one has audio, so I'll explain as it goes. But there's a transducer, this device that's put on top of the patient, and then there's a device in the transrectal ultrasound probe that it tracks. So as you put the ultrasound probe in the rectum to identify the prostate, it's constantly tracking the movements on your ultrasound. And so then you're able to sweep and map out the prostate. So here it's scanning the prostate, and we're creating that ultrasound image, which we will then fuse to the MRI. That allows us to target this abnormal area directly, find that bad seed by having a map and be able to do that. So that's kind of where a lot of this is moving towards, and a lot of that is really when we talk about precision medicine. And there's a lot of platforms that are out there right now. There's the most commonly used are probably here listed, of an Artemis system, a Euronav system, or a Coelis system. These are in the US, these are in Europe. I'm not gonna go into the specifics and details of all of these. They all have their pros and cons. We all have our preferences of which ones we use. But the concept is really using that MRI to target an abnormal area in the prostate and really maximize your diagnosis. Number of men have had negative prostate biopsies 1 time, 2 times, even 3 times, and then I've seen them and done a fusion biopsy, and they've got a high-grade prostate cancer that's been missed. African American men, there's been numerous studies showing that they typically have an anterior located lesion, which are not detected typically with a standard prostate biopsy. So there are a lot of things that we're learning about how this can be more helpful by combining the MRI to those ultrasound images. This also, I'm very passionate about, because the American Urologic Association, back in, I believe this was April of 2020, came out with a guideline statement. So this is right as the pandemic is in full force, saying that it used to be only men who had a negative prostate biopsy could get an MRI before their next biopsy. But if you have never had a biopsy, no insurance would cover it, and you couldn't get it done. And they came out with a statement in conjunction with the radiation societies to say all men should be able to get an MRI before any biopsy, whether it's your first, your second, or your 5th, it doesn't matter. And that's what I've underlined right there. And so that has really changed the biggest barrier, which was insurance coverage for an MRI. Now I can say that every patient in our practice before a biopsy gets an MRI unless there's some outstanding factors, most of which being claustrophobia. Outside of that, there are some options, including an open MRI. But majority of men, insurance issues for getting an MRI before a biopsy has really gone away, which is great. Yeah, no, absolutely. We've been doing fusion biopsies since probably about 2016, and I mean, it was so difficult to get an MRI. And now we don't even think twice about it. I don't even tell patients, that insurance won't cover it. It's really something that we just expect it's covered. So that was definitely a big game changing. The reason I brought up fusion biopsy was, one, we saw that, about 10% in the room knew what that was, but that's leading that next evolution for technology in prostate cancer. That we've heard about this with breast cancer, moving forward with focal therapy. And what we see here is now we have that ability. If I can identify an abnormal area in your prostate on MRI and I can specifically biopsy that area, why can't we treat just that area? A lot of these conversations about urinary incontinence, about erectile dysfunction are because we are treating the whole prostate. We are affecting the nerves, the muscle. But what if I can treat just this one area that's right here and minimize any effect on the nerves, on incontinence, on erectile dysfunction? That's where we're heading. That's what we're trying to aim for. Now, there are some options that have kind of been out there, and what I'm talking about right now, there is a lot of clinical studies going into this, so don't take any of this as these are standard of care treatments. I think we still have the standard of care with surgical options, radiation options, but we are moving into a focal therapy, but there is still a lot of work that's going into, is it useful? How long is it useful? So take these with a little bit of grain of salt, but I wanted to talk about what's potentially coming. As we have fusion biopsies, we can potentially focus ultrasounds directly to these tumors, that if you have only one area of prostate cancer in an abnormal spot, but the rest of the prostate is clear, I think patients always wondered, I get asked this all the time, why are you taking my whole prostate out? Why can't you just take that piece out? And so I think patients are thinking, like, why are we treating the whole prostate when it's just one single abnormal area? And that's what focal therapy really allows us to do. So, this is typically, most of these utilize either ultrasound or lasers or nanoparticles. And it's no radiation, very minimal or no blood loss, trying to have lower rates of side effects, erection issues, urination issues, while also treating the cancer. So that's what we're looking here, and the image at the bottom says that you can really treat just the abnormal area, or if a couple parts showed cancer, maybe just treat half of the prostate, not the whole thing, or you can do the whole thing. So I've got just a quick video here as well that just shows how this potential application can serve by sending ultrasound waves to really treat the prostate. It's very similar to a fusion prostate biopsy, and so it's done in the operating room where, a patient is asleep. I always describe your legs are up in the air like you're about to give birth to a baby. That's the easiest way I know for patients to understand. But we insert this ultrasound probe. Unfortunately, everything we do with the prostate involves an ultrasound in the bottom. So everything we do, but it allows us to see the prostate. And from there, similar to a fusion biopsy, we kind of map the prostate out. So by mapping it here, we're getting these images of the prostate, like a cross-section, like a CT scan of every part of the prostate. And where that abnormal area is, we're able to know where it is in a 3D space, right? We're not playing Nintendo anymore. We don't need a 2D image. We want to do everything in 3D. But then we're able to map out your MRI, your ultrasound, identify this abnormal area, and then in real time, we're then able to set the parameters of where these ultrasound sound waves go to where it can heat up that cancerous tissue and destroy the cancer. So this is where technology is really emerging in, is to minimize the side effects but still adequately treat the cancer. And so that's what we see and there's a lot of planning that goes into it. That's what's shown here. This is all planning related to this. And once that's done, we have our map over on the right side. Then you start treatment, and you're able to focus the maximum focal point of those ultrasound waves right into that tumor site. And then that's what we're tracking. With real-time ultrasound, we're able to monitor just treating that abnormal area. So this, I think, is one of those areas that really there's a lot of interest in focal therapy. Not so much just HIFU in general, but when I talk about focal therapy, I'm talking about HIFU here, and I'll kind of show on the next couple slides some of these other potential options that are also being assessed in clinical trials. So when we go to the next image here, that's just one potential option talking about it, okay? These are some other type of focal therapies that have been looked at. Cryotherapy, that's freezing the prostate. HIFU, that's high-intensity focused ultrasounds, using ultrasounds to treat the abnormal tumor. Laser ablation, inserting a laser in there. And these are showing, different disease-free survival as well as cancer-specific survival, but there's a lot that we still need to understand about this, like longevity. Is this a 1-year treatment? Is this a 3-year, a 5-year? Does this last 10 years? What are our options as we go through this? So there's still a lot of work that's being done with this, but that's what the goal is. This is, I'll just show this quick video of just kind of what Tulsa Pro is. That's another type of these different focal therapy, but I just wanted to kind of quickly show this, and then I've got one other one I wanted to show. But this is a similar concept, but here you are where we insert, that's your prostate there, you've got a catheter in place, but again, we're taking different sequences of the prostate, like a cross-section anatomy. We're identifying where the abnormal area is and then utilizing heating that entire area. So it's all done under direct vision, and it's a lot of computer mapping. It's very similar to how they do radiation, that, these simulations, things like that. So I'm gonna skip to our next one. I just wanted to show some nanoparticles, and I think I've got an animation on that as well. Nanoparticles, this is actually a clinical trial we're involved in, and this is actually very interesting, but it's taking these small nanoparticles and injecting it into a tumor. This animation's about a brain tumor, so.
Measures some 20 nanometers and is thus 500 times smaller than a red blood cell. 1 milliliter of the particle solution contains nearly 17 trillion single nanoparticles. This high density makes efficient treatment possible. At the beginning of the therapy, the nanoparticles are injected directly into the tumor. The tumor in this particular case is a glioblastoma, a malignant brain tumor characterized by aggressively growing cells. On the microscopic level, the healthy cells can be seen on the left and the tumor cells on the right. After being injected, the nanoparticles spread out in the spaces between the tumor cells. The patient now enters the therapy device in which an alternating magnetic field is produced, which is of no danger to humans. This field affects a 100,000 times alternation of the magnetic poles within the particles per second, creating warmth which is precisely regulated from outside. The warmth forces the particles into the spaces between the tumor cells, which makes it easier for them to be absorbed into the cell. This application is repeated and the thermal effect increases visibly. The particles begin to oscillate, causing the cancer cells to die either from active self-destruction or from swelling until they literally burst. Tumor growth is stopped and the destroyed cells, as well as the nanoparticles, are discharged by the body in a natural process.
So, I mean, it's utilizing this technology there, these nanoparticles, injecting these small, objects that then are heat activated to disrupt the tumor cells and cause them to be destroyed. And really kind of that precision medicine, I think that's the key term that we've heard a lot about in general. And so, I skipped a slide, but there was the punchline already. So, but, robotic prostatectomy has been around well over 20 plus years, and I mean, I think that's definitely the standard in terms of surgical options. I think majority of people you will see are doing robotic prostatectomies, and I think there's still evolution with that that's occurring, and there's every day we can get better. But there are a lot of focal therapy options that are emerging as well that I think are very exciting as we look at fusion prostate biopsies quickly becoming a standard. I think, cryotherapy, HIFU, laser, nanoparticles, any of these focal therapy options, we always want to enhance our prostate cancer outcomes and also minimize any potential side effects. That's what we're aiming for. There's still a lot of work to be done, so I commend everyone that's participating in clinical trials because that's how these therapies get approved. That's how we get insurance coverage for it. And that's where we get more data to know that, these therapies work. So continue that good work, and those are the struggles with it, but I think there's a lot of excitement coming through with focal therapy. So I'll go back to this now. Does anyone know what this is? Yeah, so it's the mannequin piss in Belgium, in case anyone wants to go visit. I saw it over the summer, so. All right, I'll take some questions if there's any questions. Thank you.
Hi, my name is Hugh Beckford. Question on MRIs. The software that does MRIs, is that a standard? Because in my case, I had 2 MRIs. Because my urologist wanted me to go so I could do have the fusion biopsy. But because of a delay, I went to another clinic, Mary Washington, had an MRI with them. It showed 2 lesions. Then I actually went back and said, no, the software is different. So I went and had another MRI at the clinic that they recommended, and that came back and said, just keep observing. They didn't see anything. So is that the software? Is that the radiologist? Because that made a difference for me in pursuing to find out what was going on.
Yeah, no, I think that's a great question. I think there's 2 points in that question. One is the MRI. It is very dependent. I think as MRIs are becoming more and more prevalent, that prostate-specific MRIs, a lot of radiologists are learning how to read those as well. With any technology, that's something that is something that we're noticing, that you'll have somebody who might read 1 prostate MRI in a year compared to someone who's read 1,000. And so that experience does matter. So we've kind of partnered with a radiology group so that we only want 2 radiologists reading all of the MRIs to try and maximize that. Because we've run into that scenario too, where someone comes with an MRI from somewhere else and it gets read again, and then we're not seeing an abnormality. But a lot of that's also from experience. When we started the program, we would meet with the radiologist, meet with the pathologist, and discuss that you called this a very aggressive lesion. We did a biopsy. It came back normal, or it came back less aggressive. How do we learn from this so we know kind of what to expect? And we learned that enlarged prostate can cause nodules and MRIs that might get called something that could be concerning for cancer. And so some of that is the experience. Regarding software, a lot of these fusion platforms all have their own type of software that has to tie in with the MRI. So depending on what software or what MRI fusion platform the urologist is using, then it may need that where your MRI has to get burnt in a certain way to be compatible. So that's where those software issues can arise as well. Yes? I think they're bringing you a microphone.
The nanoparticle clinical trials you just mentioned at the end there, is that potential for distant evidence outside the prostate? Was that specifically focused into the prostate, like you were talking about the HIFU?
Specifically focused into the prostate. So there's very strict criteria for that. It's currently for favorable intermediate risk, a Gleason 3 + 4 = 7 in the abnormal area with no real other sites of cancer. And it's for a focal injection into the abnormal lesion and treatment of just that area. So not the entire prostate, not any other sites, just of that abnormal spot from MRI that's been confirmed by biopsy. Yep.
Early stage cancer, not late stage?
Right, right. So all of these emerging technologies right now are still looking at early stage localized prostate cancer, typically even, just in one abnormal spot. So most of these are looking at men with a Gleason 3 plus 3 equals 6 or a 3 plus 4 equals 7. As more data comes out, I'm sure things will start to be expanded out, but most of it is still all looking at focal therapy for localized prostate cancer contained to the prostate.
In your opinion, do you see a pathway where some of these technologies can be used for bone metastases and such?
So there's potential. I mean, there are some treatments that are coming down, looking at alpha emitters, beta emitters, looking at all of these radionuclides. There's Xofigo treatments. So there's a lot of things that are very separate from focal therapy. Focal therapy really looking at localized low-grade prostate cancer, but there are other types of treatments that have now been emerging over the last 2 to 3 years, specific for bony metastasis or more advanced cancer. There's a lot that's kind of emerging right now as well.
So for example, PSMA, LU, that stuff, that's more
Correct.
along those lines?
Correct.
Okay,
Yep. And
thank
I
you.
didn't touch on any of that. I was more with the focal therapy for localized, but absolutely, there's a whole other talk related to exactly what you're just describing. Cool. All right, well, thank you, everybody.